All right, welcome. Today we're putting on our detective hats. We're going to tackle a really fascinating clinical problem by looking at a puzzling involuntary movement. Using our clinical reasoning, we'll work our way from just observing the patient all the way to a diagnosis and management plan. Let's get started. So let's set the scene. Imagine this. A 65-year-old man walks into your clinic. Now, you know from his chart that he had a stroke several weeks ago. His family's worried because they've noticed this new, kind of strange, flowing movement in his left hand. And that right there, that's our first clue. Okay, so right off the bat, two huge questions should pop into your head. First, what exactly is this movement we're looking at? And second, where in the brain is the trouble? Let's start by figuring out the what. The first step in any neuroexam is just to watch, really observe the patient. Before we can even think about where the lesion is, we have to put a precise name on what we're seeing. And that slow, writhing movement being described, it has a specific name, athetosis. So, where does this word even come from? Well, it was coined way back in 1871 by a guy named Hammond, and the name itself gives us a massive clue. Athenosis is Greek for without a fixed position. And honestly, that's a perfect description, isn't it? The movement is slow, it's continuous, it's writhing, and it's totally purposeless.
And I love this part. To really get a handle on it, clinicians have come up with some incredible analogies. Think about it. A movement that mimics the flowing fingers of a pianist, or, those serpentine hand movements of a Balinese dancer. These mental pictures are gold when you're trying to spot this on the wards.
Okay, so we've answered the what. We know it's athetosis. But now for the really juicy part, the where and the why. To crack this, we got to go back to basics and look at how the brain's motor system is supposed to work, and then figure out where it all went wrong. So think of it like this. In a healthy brain, your motor cortex comes up with a plan, right? Like, I want to pick up that cup. But that initial signal is a bit rough. So it gets sent to the basal ganglia, which act like this super sophisticated filter, maybe like a sound engineer, just smoothing everything out. The end result? A smooth, controlled, purposeful movement. Now, let's bring it back to our patient. That stroke he had, it wasn't just anywhere. It hit a key part of that filter system, the lenticular nucleus in the basal ganglia. So what happens? That filter is now broken. It's offline. And all those raw, unrefined motor signals from the cortex just flood right through. And bam, you get the uncontrolled, writhing movements of athetosis. So yeah, in our case, the stroke seems like the obvious culprit. But a good clinical detective never gets tunnel vision. You always have to build a full differential diagnosis. So let's look at the complete list of suspects for what could cause this sign. And wow, this list is pretty wide. Sure, we have vascular causes like our patient's stroke, but you've also got to think about congenital causes, like cerebral palsy from a tough birth. That can cause something called double athetosis. Then there's a weird one, severe sensory loss, which can cause a mimic called pseudoathetosis. And finally, you have this whole miscellaneous grab bag of causes, from toxins to certain medication. Okay, listen up, because this next part is absolutely crucial. I'm talking high yield for exams, and even more important for real-life clinical practice. We need to learn how to tell athetosis apart from its close cousins in the movement disorder family, especially chorea and dystonia.
So how do you tell them apart? It all comes down to two things, quality and speed. Just watch the movement. Is it slow and writhing, almost serpentine? That's athetosis. Is it fast, jerky, kind of dance-like? That's chorea. Or is it more of a sustained, twisting movement that gets locked into an abnormal posture? That's dystonia. That first question, slow and flowing or fast and jerky, is your biggest clue.
But here's the kicker, and this is so important to remember. In the real world, these textbook definitions can get messy. There's what we call a fuzzy border zone. Patients don't always read the textbook. You can absolutely see movements that have features of both, like choreoathetosis, which is both writhing and jerky. It just reminds you that these things often exist on a spectrum. All right, so let's recap where we are in our detective work. We've identified the movement, we've pinpointed the lesion, and we've built our list of suspects. So what's the last step? We've got to figure out management and then lock in the most important clinical pearls from this whole case. When it comes to treatment, the focus is really on controlling the symptoms and, if you can, treating the underlying cause. For athetosis from cerebral palsy, botulinum toxin injections can really help. For cases like our patient post-stroke, they've even used deep brain stimulation, or DBS. The big takeaway here is that there's no single magic bullet. And for a lot of medications, well, the jury's still out on how helpful they really are. Okay, get your highlighters out. If you're studying for an exam, these are the 4 things you absolutely need to burn into your brain. 1, the name tells you what it is, without a fixed position. 2, think basal ganglia lesion, especially the lenticular nucleus. 3, your key buzzwords are slow, writhing, serpentine. And 4, know how to tell it apart from chorea and dystonia. Got it? Okay, let's test this out. Mini case number 1. You have a child with a history of birth hypoxia who now has these bilateral, slow, writhing movements in their hands and feet. What's the diagnosis? Well, that history of hypoxia plus the bilateral movements, that's pointing straight to cerebral palsy. And a sign is what we call double athetosis. Now, this next one's a bit trickier. A patient with a cervical cord lesion has writhing hand movements, but only when they hold their arms out with their eyes closed. What's going on there? Well, when they close their eyes, you're taking away their visual feedback. This reveals a massive deficit in their position sense, their proprioception, which is coming from that cord lesion. This isn't true athetosis. It's called pseudo-athetosis. All right, you're doing great. Let's lock all this in with a quick self-test, just to make sure everything's sticking. First question, what's the main brain structure involved in athetosis? That's right, it's the basal ganglia. And if you want to be more specific, the lesion is often in the lenticular nucleus. Question 2, how would you describe the key difference in the movement itself between athetosis and chorea? It all comes down to speed and character. Athetosis is slow and writhing, chorea is fast and jerky. Okay, question 3. A patient develops athetosis weeks, even months, after a stroke. Is this a real thing? Absolutely, yes. Just like we saw in our very first case, delayed onset athetosis is a well-known phenomenon. Sometimes the brain takes a while to, well, rewire itself after an injury, and these signs can pop up later. All right, here it is. Your rapid revision, the 1-sentence summary you can use for last-minute cramming. Athetosis is a slow, writhing movement from basal ganglia damage. Think stroke or cerebral palsy. And remember, it's not fast and jerky like chorea, and it's not fixed like dystonia. That's the whole story in a nutshell. And that brings us to one last big picture thought. Since we know this fuzzy border zone exists between athetosis, chorea, and dystonia, how does that challenge how we think about, classify, and even research these movement disorders in the future? It's a really interesting question. Thanks for joining me for this explainer.